Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank the following Keystone funding partners for their ongoing contributions that support all of our programs and activities: the Stollery Children's Hospital Foundation, BC Children's Hospital Foundation, the Children's Hospital at London Health Sciences Centre, the Alberta Children's Hospital Foundation, the Children's Hospital of Eastern Ontario, and Holland Bloorview Kids Rehabilitation Hospital. We would also like to thank the organizations that provide funding for our knowledge translation activities, which includes this Spark Live webinar series, the Spark Conversations blog, and the Knowledge Exchange Network. To learn more about Children's Healthcare Canada, you can go to our website, follow us on Twitter or Facebook, or you can sign up for our weekly Spark newsletter at childrenshealthcarecanada.ca/email, where you will learn about upcoming events, read the latest posts from our blog, and other exciting news and events from across the child and youth healthcare community. Hello, everyone. I'm Doug Maynard, and welcome to Children's Healthcare Canada's Spark Live webinar series, where we curate and convene and showcase excellence and innovation from across the child and youth healthcare community to spark conversations, ideas, and action. And since we are live, these presentations are live, I do want to remind everyone that you do have the opportunity to type questions into the question box at any time during our presentation. We'll check for questions throughout the sessions, so please don't feel you need to wait until the end when we call for questions. Please type them in at any time as you think of them. And also feel free to share your thoughts on Twitter, and be sure to tag us at Child Health Can. All right, and today we're talking about advancing care innovations in the community for individuals with medical complexities. And I would like to just say at the beginning, I normally have someone with me helping me with the presentation here. I'm actually flying solo today, so I can't promise this presentation will run, at least from my end, as smooth as it should. I also was told to let the audience know that one of our speakers, Colette, has a cold today and may or may not be participating with her part in the session, but the rest of her team will be taking over there as well. Just wanted to say that children with complex medical needs, this is a very interesting session for our community. It's been an area of particular interest for Children's Healthcare Canada for many years. We've had a community of practice focused on the development of guidelines in this area, and that work continues with a focus on supporting children with medical complexity as they transition, not just from pediatric to adult services, but supporting their transitions throughout the various settings of care and the continuum of care. And today's presentation, again, is of particular interest as it gives us an opportunity to showcase one of Children's Healthcare Canada's members and highlight some of the great work going on within our very own child and youth healthcare community. So with that, I'm going to introduce our panel. Today we have with us three individuals from the Safehaven project for community living, which is based in Toronto, Ontario. We have with us Susan Bissayon, who is a registered nurse and is the Chief Executive Officer at Safehaven. We also have with us Catherine Burbage, who's the Manager of Quality Safety and Strategic Directions at Safehaven. And we also, as I mentioned, have Colette Montague, who's a registered nurse and is the Director of Programs Programs and Professional Practice at the Safehaven Project. So as I'm trying to hand the screen over to our presenters here, you can see me stumbling as I'm trying to do this and speak at the same time. So with my apologies for that, but it's my pleasure to hand the virtual podium over to our team down in Toronto at Safehaven. We'll be starting, I believe, off with Susan Bissayon. Over to you, Susan.
Okay, thank you, Doug. That's great. And I'm actually, Doug said that one of our presenters is not feeling great today, so I will be doing the slides for Colette. She is here if we have some questions. So I'll just get started. So we're very excited to talk to you about our organization and all the great work that we're doing and really looking at care innovations in the community, and with particular focus on sort of those high-need pediatric kids who have medical complexities. So sort of the agenda that we had for the program today is really looking at who we are and give you a sense of our services. And then we'll also talk about how that's actually advancing the last few years and how we're growing. Also look at our strategic plan just at a glance in terms of what our focuses are for the next few years. the need for innovation, so some of the work that we're doing around innovation, and then really take a little bit more of a deeper dive into that focus on care innovations in the community around our structure and what we've done around the focus on quality, education, and our partnerships. And then just give you some high level of, what's next for us. And I would say that we're very excited. We joined the network a couple of years ago, and for us, this is a great sort of way for us to really partner and also share information and learning with you, but also to receive that information back to advance care in the community. So as you can see from an introduction, Safehaven started over 25 years ago as a grassroots organization, and really it was a group of family members that came together. It was what some people describe as a crisis, a provincial crisis, and they really were instrumental in developing what they wanted was facilities in the community that felt like home-like settings, inclusive environments for individuals with medical complexities and disabilities, children and youth. And it was very successful from the start, and over time, has grown. You can see over that 25-year period, and I use the 200 or 2,000 families plus, is probably more. One of the things when they started off, there was no database. And I think those are some of the challenges that we still are working through, is like data collection and all that, but certainly a lot of families. So we now have grown to 5 locations in the GTA, the Toronto area, in North York, Etobicoke, Aurora, Woodbridge, and Toronto. So a lot happening at those sites. So who do we serve? So in terms of we service children and young adults with medical complexities, technology-dependent or life-sustaining equipment. A lot of these individuals, and some of the current young adults that we have living with us, are individuals who actually have aged out. So initially, the organization was set up as a pediatric organization. We have approval over the last few years to move into the transitional age youth. But these individuals actually, there's currently 6 young adults who live with us, and they actually have aged out. And I think the thinking was, when in speaking even with some of those families from the start, was families were given that this would be a location for life, but they never actually thought that some of them would make it to over 20. But with all the supports, they've done well. We have individuals with a variety of different cognitive abilities. They may have a lot of individuals with neurological disorders, seizures, different types of ostomies, wound care. Some of them have central lines, catheters, trachs, oxygen therapy, CPAP, nutritional needs around G-tube, G-day tube. We also take kids with behavioral issues, but we have to be careful about that because we do have a lot of very vulnerable kids. So there's quite a work goes into looking at that. And the other piece, which is on this list, is currently we do have children who actually have ventilation. So we do take pediatric respite ventilation, and we will be moving into pediatric residential ventilation. So we will have individuals move in with us who are on ventilators. So the organization provides 2 types of services, residential and respite. So the residential services, really there's a lot of children or clients that come to us really when that whole sort of, burden of care is overwhelming. We also have individuals who, actually are crown wards. So we have children who are, for a variety of reasons, they don't have the parental support, so they live with us full time, and that works out quite well, and they're certainly a part of the family. We do see ourselves as a family unit, and the staff are very connected to these kids, so it is considered an extension of the home. We really work on the environment so that it does feel comfortable for clients and their families, and really it doesn't have a feel of an institution. And there's a strong focus when the organization started on family involvement. Because it was a grassroots organization, the whole notion of family involvement is very strong, and families are welcomed, in whatever way their capacity can be or they want to be, but certainly there's a strong focus for family involvement, not only in care, but even in terms of committees. And we do have families, who have individuals with special needs on our board. So lots of involvement with families. In terms of the respite care, we have one location in downtown Toronto that really serves as the respite facility. We can have respite in the other locations, but predominantly in the Toronto location, we service probably about 170 families who come in for respite. And this is 24/7 care, and it really gives the families that opportunity for sort of that, I call it recharging, sort of mentally, physically, and emotionally. And also, there's times when, many of these families have other kids, so it gives them an opportunity to focus on not only themselves, but other siblings. And the other big piece is that while there's a lot of care complexities that many of these children have, we also really work a lot on sort of the experience of coming to respite. So in terms of meaningful experiences, opportunities for learning, growth, and development. And again, the social inclusion, which we know is a huge component. A lot of these kids have social isolation. So any way that we can really enhance the quality of life and their experience when they're here at respite. And being in Toronto downtown, there's a lot of sort of activities and venues that we can take the kids out to. So I think, having accessible subway lines, having access to we have a Scotiabank arena for concerts, the Blue Jays, the aquariums, the museums. So there's a lot of outward focus activity in terms of getting these individuals engaged in the community. So in terms of looking at our strategic plan, so a few years back, we actually embarked on the development of a strategic plan. Our strategic plan is from 2017 to 2022. A couple of things that we were really wanted to focus on in this strategic plan was, one is the elevation of quality and safety. We, as an organization, there was a lot of focus here, but we certainly we were not an accredited organization. So one of the big pieces for us was focusing on accreditation with Accreditation Canada. The other big piece was provide services from childhood through to adulthood. Again, what we see is that the system is really not created for these individuals. Once they reach 19, the age of majority as an adult, there's really very little available. So we really took on this piece in particular to really look at how can we be that service provider for when these kids age out. The families describe it as falling off a cliff when they reach their children reach 19. So we have done a lot of work and will continue a lot of work in this area. The other piece in terms of expanding innovative programs and service offerings, the last 3 years, one of the things we've really done is really sort of evaluated our criteria for admission and for respite care. Because one of the things that certainly that I felt when I joined the organization 3 years ago, that there was probably more that we can do. The criteria was restrictive. So we've really looked at making sure if somebody's in the community who has a lot of complexities, that we ourselves would take on the education and the programming to be able to provide that support for respite and or residential care as needed. The other component is around the client and family centeredness, so really strengthening our bonds with clients and families, and also our partners. While there had been partnerships that were formed, there were certainly areas that needed to be heightened and strengthened, so we've really worked on that. And the effectiveness, certainly there's been a lot of work in this space in terms of revamping our protocols, really alignment with our academic centers, alignment with best practices, joining committees to really kind of look at how can we be effective, not only in terms of how we deliver care, but making sure that it's evidence-based and that we're really kind of doing things that are aligned with what the best type of approaches that are available today. And internally, we've done a lot of work in terms of automation. So looking at how can we sort of look at every area that we're doing that currently exists in paper. Are there systems out there that can really help us become more effective? And also even in terms of our structures, our leadership and the board. So there's been quite a bit of work there. The values, again, really looking at a lot of work in terms of our stakeholders with our families, the staff, board members, and leadership, making sure that we do value sort of the focus on sort of quality and safety, that focus on client-centeredness, respectful interactions, also accountability, and also really looking at the team values. So really looking at having those as sort of our base values. And we actually took our values and did a significant exercise in really converting that into promises. So really sort of having everybody, make those promises that they would be focused on. I promise that I'll be focused on sort of providing high quality safety care. I promise that I'll be accountable. So there was a huge sort of engagement with staff that really helped us take that and convert it into promises. In terms of why do we need innovation, we know that there's a lot of Canadians and individuals out there who have disabilities. And these are just some stats. Like the stats in this area would have to say are not the best, especially with children with a lot of complexities. And you can see it there, like over 160,000 of those 8 million Canadians age 50 and older were identified as having developmental disabilities. And there is a significant amount living in Ontario, about 40%. And 9 of 10 of those individuals also have at least one other type of disability. So and then we are working to refine the stats more and more. There's a lot of individuals it's really hard to get really sort of solid information, especially on the high-end sort of complex special needs. And in terms of the work in the community, there is a huge wait list for service. This one here is really from the developmental sector, and that the last sort of review that's out there, there's over 14,000 people on the wait list for supports. Most of this is residential support, and there's a significant need for children who age out from youth children's services into adulthood. We're struggling. We've been in contact with other organizations across the country, and this is a significant issue. Then you can see there the numbers that came out of the 2016 Ontario Ombudsman report, which really identifies the wait for residential care. And I think the thing that we don't see a lot of, which we know is an issue, is a lot of families really try to avoid residential care as much as possible. And with that being said, they do appreciate respite. Respite is what keeps families together. So having those short breaks, having those weekends a week, summer vacations where they can have some respite, certainly we wish we could have more solid information on the wait for respite, but that's not available at this time. In terms of innovation and care, I'll just talk about some of the things that we've done over the last few years. Really, a lot of it is around professionalizing the organization, looking at our structures to focus on quality education and partnerships. Certainly, one of the big things for us, and with the governance work, we revamped our entire governance framework and really aligned it to best practices in governance, and really sort of brought on some new kind of thinkers, people who can help us with the innovation that was needed to happen in this space. And our leadership structure, once we had our strat plan was really looking at what was it we needed. So we really sort of looked at one example, like Colette's role was really looking at the whole role of programs in professional practice. We really didn't have enough nursing support. So doing that recruitment to get people who had the nursing background, who had that expertise in pediatrics to come on board. And Catherine's role also, for example, is another role in terms of helping us lead with the quality and the strategies and quality and safety as we move forward with accreditation. And in all of our locations, one of the things we heard was there wasn't enough support for advancement and leadership at the front line. So we really sort of looked at junior leadership roles, creating sort of in each location a client care coordinator to help sort of oversee the operations in each of those areas. And also then in terms of education, hiring a lead role, a nursing role for education. So that was some pieces that were missing. So I would say that all the roles in the entire leadership and frontline have been revamped to align to the strategic plan. The next slide really speaks to our focus on quality. And this one is really Catherine. So I'm going to hand this over to you, Catherine, because this is your work.
Oh, thank you. So a big initiative for us, we had never been accredited before. So when Susan signed on in 2016 as CEO here, she said that we're just going to need to go ahead and get accredited and get in contact with Accreditation Canada. So that was 2 years of work, and in June 2018, we had our first on-site survey with Accreditation Canada, and after 3.5 days and 2 years of work, we were excited to come out with accredited with a commendation. So for our first accreditation, we were pretty excited about that, and that really goes out to all the frontline staff who put in a lot of work and on all of our committees, and we're really engaged in the process. So in order to do that, we really embedded quality in the work of our board, started there. We brought on individuals who had that quality, safety, risk background. We created a board subcommittee for quality, safety, and risk, and we just really were reporting to them quarterly to ensure they were aware of everything that was going on with regards to quality within the organization. We standardized processes, and that is from anywhere from our intake processes and streamlined those, made them more efficient and lean, really worked with our families as well on that to get their feedback to ensure they were happier with the processes. We worked with staff as well on our medication reconciliation processes and education to ensure they were all confident in using those new processes. We updated all of our policies and procedures, so that's an ongoing work for us, but that was a big piece for us as there was a lot of probably not up to par policies, so that was a big piece of work for our leadership team, and staff engagement through new operational committees. They didn't really have committees here before, so it was really getting them involved in the process and making sure that we had the buy-in from the staff and that they were able to take ownership of these projects and were proud of the work that they were doing. So we started what's called our best practice committee, as well as a quality, safety, and risk committee, an ethics committee, and along with ones we already had, such as our occupational health and safety committee. So that was a big piece of work for us, and I think the staff really felt involved and appreciated that opportunity. And the picture here is just how we engage staff in all the locations of our journey towards accreditation. And then the other piece was the modernization for a focus on quality. Modernization of all 5 of our locations for safety, comfort, quality of care, and I know Susan can really touch on that a little more as well.
Yeah, no, that was a key piece, and certainly some of the standards that we needed to do better in terms of the environment. So we're quite pleased that we did all that work to help us out. So. And just to let you know, even though this speaks to accreditation, we are licensed under the Ministry of Children's Community and Social Services, and we have to maintain that license. It's very strict. So every year there's quite a rigorous process that we go through in terms of maintaining that license. In terms of staff education, this is Colette, but I will focus on it again with the hiring of Colette in her position, and really the focus was we really had to develop a formal education program. So what we did was we heard from the staff through our work-life pulse was that there was a huge gap in terms of education, like pages and pages of people felt that they didn't have the skills and they didn't have sometimes the confidence. So we really said, okay, this is a huge priority for us. So the education and hiring people to help us with the education, partnering with some of our external sort of organizations like in the pharmacies who've actually helped us with medication education was big. And then also Colette developed, mandatory programming, sort of to look at annually, the mandatory annual observed structured clinical education, and then also the Control Act. So that was huge. And now, so there are dedicated skill days twice annually for the staff on top of other education. And the thing is that staff now are really pleased with it. We're getting a lot of positive feedback. And then we're even building on that. So we're now have modules, access online. And not only are we doing professional development days, which I talked about, but we also, because we're small enough that we can actually have people involved in strategy. So one of the big pieces, what I talked about prior, was about the values. So we do cross-organizational work, bring people from all sites together, talk about what, the values and our promises, and how do we actually want to see that lived every day. So there's been work. We've partnered with Deloitte firm to help us with that. So we're quite excited with that work that we're doing in terms of elevating the education, yes, in terms of skills, but also some of the other pieces around teamwork, how they work together. And really a big piece for us was creating like a just culture. Because one thing we saw was that there was a lot of focus on, initially there was a mistake, it was more of a blame culture. So really trying to remove that and focus on, well, what really happened here? How can we improve it? In terms of in May, we were able to collaborate with the new project that Sick Kids was leading on Connected to Care. And the goal was just to provide education to nursing care for children with medical complexities and life-sustaining equipment in the community. So from this work, this has been fabulous in terms of having these resources sort of on our doorstep, to really sort of educate the staff around different things, different modules around vascular access, enteral feeding tubes and therapies, pulmonary clearance, and then trachs and ventilators. So I think that that's been a huge plus for us in terms of those partnerships to help with the education with our hospitals and academic partners. And recently, Sick Kids Connected Care team developed and revised the modules to really look at unregulated workers supporting children with medical complexities and life-sustaining equipment. So we will be part of this pilot that will be the first in the community to have these unregulated workers attend the sessions. And to date, we do have 9 unregulated staff who are trained. So just to give you a sense of our staffing model is we have both regulated nursing and we have unregulated staff who actually work for us. And the way it's organized is we have one worker for two children. But depending on the child's need, if it is a child that requires one-to-one care or nursing care or a different model, we build that model around that child when they come in for respite. For example, there's some kids who have medical complexities where it is a one-to-one 24/7, and we
need 2 workers per one child.
Right, 2 workers for one child. That would be sort of the higher end is a child who has to have two nurses for one child. But again, we build that model for that child when they come in. But the base model is an unregulated staff, and I would have to say that some of the kids that are stable, they do have, obviously, they have medical complexities, but if they're stable, they're on a regular medication regime, they've got good support with their pediatricians and their primary care, we actually do well with them coming to us. And we have a close oversight with our nurses to actually see if there's any changes in care. So there's lots of sort of ongoing collaboration that's going to happen this year in terms of having all of our frontline staff trained with the connected care. And just last year, Colette was fortunate to join the Connected Care Advisory Committee with Sick Kids. So that's a good partnership for us with that connected care. In terms of, like we talked about, sort of our in terms of the partnerships with our family, one of the big things for us was really looking at that family partnership. Well, we always had a strong focus on families. Families, part of our bylaws, that families do sit on the board, or in the family, families who have a child with special needs sit on the board. So we have a minimum of 2 individuals there. But we've also then developed that a family partnership council. So that really was a big piece of work that happened over the last few years that Catherine's leading. And I don't know if you want to say anything related to that, Catherine.
I think it's a growing journey for us, and it's been exciting. We started with probably 4 families, I want to say, and now within the last year we're up to about 6. So 6, 7 growing. So we're excited to see that. We know that our families and clients don't have much time to share with us, and so we really appreciate when they are able to, and we try to make sure that we can accommodate them in the best way possible. So it's definitely a journey for us. We're learning as we go, and just trying to get the families involved in every aspect of care and planning and decisions that we can.
Yeah, and while we have the council, which is small and it's growing, there's a lot of touch points in terms of after respite follow-up calls to find out how the visit went, what worked well, what didn't work well. You know, really taking the opportunity every time there is those touch points with family, you know, what's working, how can we do it? You can imagine with these kids, there's a lot of need for communication and handover of information because it's, you know, there's a lot of things to manage when they come in for care. So we'll continue on this, and certainly Catherine's been partnering with some other groups that are out there to help, right? And the other thing is, go ahead, in terms of with Holland Bloorview in 2016, we actually had some conversations about how we could really look at some of the ALC clients that were in the hospital and how we could develop future programming. So one of the areas that we really focused on, which is the third bullet point, is transitioning individuals with medical complexity who are on chronic ventilation. So that work is well advanced. You can imagine it's taken a lot of effort because it had to be thought through very carefully in terms of just the design of the facility, upgrading the electrical, working on the medical model in the community, the partnerships for acute care through the team at Sick Kids, also with Holland Bloorview for the neurodevelopmental component.
Toronto Central LHIN.
Yeah, and the Toronto Central LHIN. So this has been a huge effort, and we're at the point now where we're in the middle of the transition. So it's going quite well. And again, lots of sort of education, shadowing, our staff working, you know, at the rehab hospital to shadow the staff to really get to know the care needs, how we can, you know, make sure we're all aligned, and vice versa. When they first came for their visits, then we had the staff from the hospitals actually come into the community with us and support our frontline staff, RPNs, when they started to provide care. So we're quite excited about this care innovation in the community, and certainly we're now at the point where we're looking at even expanding this to other populations. And as you can see, there's lots of partnerships. Like I said, the Ministry of Children and Youth Services and the Ministry of Community and Social Service, this now with our new government has merged. So it's the Ministry of Children, Community and Social Services. So that is a huge piece. The Aid Society, the Children's Aid Society of Toronto and York, because we do work in Toronto region and also in Central region. The Catholic Children's Aid Society, the LINs, the CCACs now, which are incorporated into the LINs, and Emily's House, Catalpa, Skylark, our hospitals. A lot of work with the schools. Like all of our kids, when they come for respite or residential, they still go to schools. So there's a lot of back and forth with the schools, developmental services, and now the Children's Healthcare Network, which we joined a few years ago, and the other hospitals. And Remedy, who's our pharmacy, they've been excellent partners. They also have some very innovative sort of technologies that we used in terms of our e-modules for med education and
Public health as well, too.
Public health.
Very instrumental in our
public health.
infection prevention control.
No, that's great. And the other piece is we've really welcomed a lot of sort of partnerships around education. So I would say in the last few years we've got a huge variety of students coming from both university, community colleges, faculties of nursing, medicine, occupational health, social work. We also, in the last semester, had 4 students who are in the master's program at the Ontario College of Arts and Design University who helped us on health system design, business students from Rotman. So there's lots of sort of work with the education colleges and university. And that's really helped us elevate some of our projects, especially around the strategic plan. And then, and again, continuing to develop those new partnerships. The OCAD one I talked about in Rotman, and they've really helped us on the transitional age youth. And we're meeting this morning really looking at Humber College Commerce and Management. They also want to work with us in 2019 to help us on working on business cases and some other programming to really look at the economic impact of our programs, because we can actually provide really good care, and sometimes the cost differential is very different from some organizations. So really in terms of helping out some of the system impacts and ALC impacts. And the Partnerships for Fun, which is the ones that Catherine's going to talk about.
Sure. So Partnerships for Fun, we try and have lots of fun here. So, well, the kids have fun too, but us workers. Partnerships for Fun, dedicated individual for recreational programming and fun experiences. So in the last year, we noticed that there was a bit of a need there for someone who was focused on creating fun for our respite and residential individuals. So there, we now have a part-time recreational coordinator here in the office working on that. And she's been able to bring in lots of great programs. So we've partnered with George Brown College, piloting a clown program at our Bloor respite site. She's also brought in OCAD University students to provide art therapy for our respite clients, which has been great. And there's been lots of collaboration with different community partners who have been either bringing in events and funding those events within our location. So, for example, in December, we had a great holiday pancake brunch with Santa and Frosty and everyone coming in. And it was a great time with lots of our families and staff coming together to celebrate the holidays. Or there's also different community partners who have welcomed us to external events. There was a great skating day with a local hockey team who took some of our kids out on the ice and pushed them around. So it was just an opportunity for inclusion and to get out into the community as well. And a big focus around that was also the growth of our volunteer program across all 5 sites, so that we can ensure that these activities are able to happen for our one-to-one care in the community. And this is just a sampling of some of the different organizations that we work with. Angels from Heaven Youth Foundation donates a good portion of funds every year so that our kids can get out in the community and have lots of fun. And in the past few years, we've been working with a lot of other organizations, tickets to events, even the professional days, RBC, PwC, Deloitte, they all come in and volunteer, spend the day baking and doing crafts or helping or also providing their business knowledge and volunteering with the leadership team and giving back that way. So it's been great, lots of great opportunities for us and our kids.
So what's next? So this is sort of, we're now sort of 2019. Our plan was 2017, so we're 2 years into our strategic plan. I think you got a good overview, sort of all the exciting things that's happening on a variety of fronts for those first 2 years related to our strategic plan. We are in growth mode. So we talked about the over 18. So for us, it's looking at expansion. We are in the middle of looking at new properties and growth, and also rethinking our model, so that we can care for more individuals in a location and also provide more services. So that's the big piece there. And also in terms of our fundraising, the first 2 years of, I would say, of our strategic plan, a lot of it was inward focused. Really, I think it's like building a lot of building blocks, expanding criteria, looking at quality and safety. And we're also really now, there's a huge focus on our charitable arm in revamping that, and the communications to really sort of make sure that our message is out there in terms of what we do, that we're expanding to support sort of programming for pediatrics with more complexity and the young adults. So those are the big pieces that we're working on as we think to the future. And that's it. So if you have some questions, that would be great.
Thank you very much. Oh, sorry, go ahead.
Yeah, how you can follow us.
All right, perfect. So definitely, everyone, take note of that Twitter handle, and I assume that's probably your Facebook handle as well, Safehaven TO.
Yes.
So please go ahead and follow them, and you'll hear lots more about their activities on an ongoing basis. So thanks for a great presentation. I mean, really showcased, I think, a real need across the country when you start talking about things like ALC and all those sorts of challenges that our acute care centers face in getting patients back out into the community. I think you are really filling a gap for sure. So now's the time to ask any questions that you would like of the team from Safehaven. The first question that came in was around the educator role. They were just wanted some clarification around the sort of a little more specifics around what the nurse educator role includes. Does this person educate staff only, or do they also educate patients and or families about care needs, equipment, et cetera, if needed?
Hi, Doug. It's Colette. I'll do my best to answer that question. The educator role that we have right now, the person in that role is an actual RN, and she does do education to staff, family, and clients as well, too. It's not just focused on our frontline staff, but her role is actually to oversee the education program that we had in place and to enhance that and see what are the needs based on feedback from staff and from families. And just recently, we've been working with a family with a child who has a ketogenic diet, and just working with our staff and our family to make sure that the unique care plan that she has incorporates understanding how to use the glucometer and working with the family to make sure that those that information is correct, and so that when she's here for respite stay, that she's available, that it's clear and the instructions are clear for the staff to use.
Yeah, so just to build on what Colette said, it's a bit of both, but the focus really is to make sure that, because every child that comes in is quite unique, so it's making sure that education plan, and depending on what their needs are and their equipment, that everybody understands it. So there's a lot of work with the family back and forth, and working to make sure that we have all the knowledge when they come in for care. So it's a bit of both, but I would say predominantly the role of the educator is for the staff.
A couple questions coming in about sort of the funding from the funding area. The first question was just in general, is there any cost to families for your services, or is it all provincially funded?
So it's provincially funded. There is a minimal cost to families, which is $20 a day or $40 for overnight. And we never turn anybody away. So if anybody, comes and needs support and don't have any funds, it's certainly everybody's welcome. So we are funded our operations with the Ministry of Children, Community and Social Services. And then for the extras and things we need, we're funded actually, like I said, we do a lot of fundraising. So if we need, capital enhancements, whatever, we usually do that through our charitable arm, but all the operations are funded by the ministry.
Talking about being, you talked a bit about the requirement to have a license with the ministry, and the it's quite a rigorous process to maintain your license. And you also talked about the accreditation with Accreditation Canada. Does the accreditation through Accreditation Canada support that licensing, or are they two completely separate things?
So they're two separate, very distinct sort of approaches. The accreditation is really, for us, was important, that alignment with the national standards. So we do that component, and that's great. What I would say is that it does align nicely with the licensing requirements. I want to say, call it 280 licensing requirements.
There's probably closer now to 500 with the new proclamation that's come out. So yes.
Okay, so Colette knows that one better than me. But they do there's a lot of synergy and alignment with the accreditation and the children's licensing, but they're totally separate. And but in the end, we can say with a lot of confidence that we think that the changes with the new proclamation that came out last year and the accreditation, we certainly feel much stronger in terms of our position around quality and safety.
They were certainly quite happy to hear that we've gone through Accreditation Canada, and on our last licensing or compliance review, they call it, they actually commended us on our documentation and our intake processes, the standards that we went above and beyond the ministry licensing compliance.
So just another question back to the funding piece. Is there any difference, or can you describe if there's any sort of anything to consider when you're talking about the funding coming for nursing or regulated staff versus unregulated staff? Do they come from different pots, or is it all just sort of the same pot?
No, well, it depends. If there are individuals who do require nursing, we do actually, there are resources that are available that you can apply for nursing support within Toronto. So we do receive those funding envelopes for the enhancements for nursing. So that's over and above. The ministry pays funding. Basically, there's a base model, but over and above, we do tap into other sort of respite supports and bodies to actually receive the top up.
And do you have a pediatrician on staff, or where does physician support come from?
So they're not actually employed with Safehaven. We have the pediatricians, two in particular, who have been aligned with us for decades, and they will do sort of in-home visits. We also have a past board member who works at Sick Kids and has her own ambulatory pediatric community group. So we use her in terms of, seeing our kids. So most of the kids will have primary care pediatricians and primary care practitioners who we do work with in the community. If somebody's here for respite and there's an urgent request, we'll go to an urgent pediatric clinic that we have a partnership, or if it's an acute care. So if we have kids who have need acute care, they will go to the hospital. But certainly we work very closely with our pediatricians and primary care in the community.
All right. The next question was, can you accommodate emergency respite? So, for example, if a family member or a sibling or someone becomes suddenly ill or something like that, do you have the ability to accommodate sort of short notice or emergency respite?
Absolutely. I think we do that quite often. And, we always are available. Like I said, because we operate 365, 24/7. I don't think we've ever turned anybody away in the last year who need emergency support. And it comes in a variety of different ways. Like I'll give an example, a single parent who has a child with medical complexities and all of a sudden needs to have an emergency surgery. So we have done that. We've also had families where they've had emergency family issues overseas, where they've had to, have the child come with us. So we do actually support emergency respite, and also, again, working with our child welfare, we've had situations where we've had to be involved in related to sort of if there was a situation where a child with special needs was in a compromising situation, we certainly have taken and provided emergency support there. So this is definitely a sort of a focus of ours, is the emergency care and respite.
The next question is coming from a PhD student with a research focus on improving supports during and after transition for youth with medical complexity. And she's wondering if you were talking about expanding to new sites, and she's wondering if you will be expanding to open new sites specifically tailored to the youth population, or will the youth population be spread out over others, like across various sites?
It'll be youth. So for the transitional age youth, we will be having multiple sites. For us, it's around the capacity in terms of how many sites we can have sort of in construction and planning at the same time. But definitely, as an organization and board, we're earmarking a minimum of 2. There could be more, but we will have children and youth and young adults who will be, cared for in those sites. If, the PhD student is doing research, we're definitely interested in, we don't have any research support, but we'd love to be engaged in some research in this area if anybody's on the line and is interested as we grow.
There's an interesting opportunity right there. Right. We are just about out of time. A couple more questions here. So if you do have any last minute questions you want to type in, I can see a couple more coming in here. We have about 5 minutes left, so we'll try to get through all of them. This question is saying, just apologizing if perhaps she missed this in the presentation, but just wanted some clarification around when a child with more complex health needs, for example, trached or ventilated, et cetera, is at Safehaven. Is there an ongoing connection with home care for that child or does Safehaven manage all the care needs and connect with physicians or acute care as necessary?
So we do all the care. If somebody comes in and they're in service in the community, that in services that provide when they're at home, they cease. So when they come in with us, we take over the whole care, all the care delivery, the assessment. If there's an emergency, we'll do the connection with the primary care. So if somebody's getting nursing support from a community agency in the community, they do not come into our organization. And they might want to connect with us for information transfer, but as a rule, they would not be involved. We have our own staff.
Right. All right. Do you have, can you outline any terms related to respite care? For example, how many days per year a family could use or something like that? Is there any limitations or parameters around the respite care?
You know what? We try to keep it very open. I know there's some organizations to provide respite and they're very strict, like you can have 10 days a year. We're not. We're more flexible, but we do try to make sure that we balance out everybody's needs. There's a lot of requests, and some people want more than others. But at a minimum, I'm thinking in the summer, like everybody wants, they would book the whole 8 weeks summer. But as a rule, we give people a minimum of 2 weeks during the summer, but we have had requests for longer, and we do that. So I guess the long and short of the answer is we try not to be restrictive and saying you can only have X number of days. We really, really look at the big picture of how much we can provide and how much we can give, but really balancing it out. So really the answer is no, we don't restrict. I just say some of the peak periods in the summer, people may just get 2 weeks, even though they would like some of them to book the whole summer.
Sometimes they may end up on a wait list, which we can accommodate it depending on cancellations, but absolutely we try not to restrict our respite accommodation.
Now, as you grow, do you see that becoming an issue, just trying to be so accommodating? Like when you talk about growing to increase the size of your sites or more sites, do you see that being a problem?
I don't see that as being a problem, and I think it's really important that we try to provide that service delivery for families. Respite keeps families together. So if we can, give people an extra week or 2 weeks or whatever they need, and knowing that will keep that child still at home, that's a better option than having to, put your child in full residential care. And when you think of a bed, being able to use the resources of a bed 365 days a year, you can provide a lot of respite for families with just one bed. So for us, we're very strong believers in the respite alternative, and I think that's where we think that where the system is not developed for the young adult, that's where there's a lot of need in that area, because people don't really want to give up their young adult to residential service, but they do need respite. They need a break.
Do you have?
Sorry?
How many beds do you have in your center?
Depends on the locations. The large respite facility here, there's 15. Other locations we can have 7, up to 7. And with the new builds that we're looking at much larger, but in terms of the actual volume. So as a part of our future plan, we will be doing much more in terms of the actual capacity.
So we just have a couple more questions left, and we are just about out of time. So I think we'll take these last 2 questions, and then we'll wrap it up. But this next question is just asking if you have an assessment tool that you use for screening patients at Safe, like for your services and or for developing care plans. And if you do have one, is this something you can share?
Yeah, we do have an assessment. Colin, I'll let you speak to that.
So we've actually had a lot of discussion with some of our partners at Sick Kids about assessment tools and what to use, and it is quite a bit different from acute to community. But I am on a lot of the assessments, especially when it comes to nursing. As for a specific tool, we basically have a checklist what we use, and we created that, and we actually shared that with partners through Holland Bloorview and through Sick Kids, who didn't approve it, but said, you know what, this is really good for them to have, so that when they're basically filling out a referral form, they'll know exactly what they're looking for. So as for a specific tool, no, but for sure I could definitely share sort of our referral tool that we use and the contacts that we have through Sick Kids that we use.
So I would say if somebody needs something, to contact us directly.
Directly, exactly.
Yeah.
So contact myself directly or a social worker, and we'd be able to help you decide on what type of an assessment and who would be involved in that assessment.
Last question we have, and after this question, we'll just hand it back over to you. Maybe we'll just hand it to you, Susan, for any closing comments that you want to give. But the final question we've got here is just asking about psychosocial support, so social work or psychologists or anything like that. Do you provide any of those services?
So we do have social work. Do we have psychology? No. Again, though, as we're growing and looking at different issues, there is probably an opportunity for psychology support. And I've had a conversation yesterday about looking at some additional support. So right now, we just have social work. I do think that potentially we can incorporate different services as our programming changes.
And I think with that great presentation, I think we'll just hand it to you, Susan. Any key messages or closing comments you'd like to make to send the audience off with before we wrap up?
No, and it'd be neat for me just to see, Doug, like, the composition of who was on the call, but certainly for us, I just want to thank the Canadian Healthcare Canada for having this, because there's such an important need, I think, for organizations like ours to really partner and connect with other organizations and with hospitals. And I do think that the way forward for Safehaven and how we truly sort of embrace and care for these kids, we're going to really need to really everybody work together, and that's when we know we're going to be able to fulfill the needs. So we're excited about our future. We've got a lot of things that we're planning, a lot of growth, and we're just excited to be a part of this and look forward to further presentations.
All right, thank you. And with that, I think we'll wrap it up. So thank you once again for a great presentation to all three of you, Colette, Susan, and Catherine. If you do have more questions for them, you can certainly reach out to them through their Facebook, Twitter, or their website. Or if you do have trouble getting in touch with them, you can always contact me, and I'll certainly be happy to pass their information along to you. Okay, all right, great. So we do our webinars every Wednesday at 11 a.m. Eastern Time, and it is great when you can watch live, as your questions, as you can see, really enrich the discussion. But when you can't watch live, we do record these sessions. I know someone asked that question earlier. We do record these sessions and make them available after the fact on the Children's Healthcare Canada Knowledge Exchange Network at ken.childrenshealthcarecanada.ca. You can see the URL on the screen there. Our next webinar will be next week, as always, on Wednesday, January 23rd, and we'll be hearing from one of our poster winners from the 2018 annual conference of what at that time was still called CAFC. The winner in the scientific and quality improvement category was Mohammed Khan, who's actually a student at the University of Alberta, working with a team as well in Alberta at the Glen Rose and the Stollery Children's Hospital in Edmonton. And Mohammed and one of his supervisors, Carmen Rasmussen, will be joining us to talk about exploring the impact on caregivers associated with perinatal stroke. So I think even for this group here, potentially some interest in that topic. So hopefully we'll see everyone back here next week. So thanks again for joining us today. And again, hopefully we'll see everyone back here next week. So thanks again for joining us, and thanks again to our partners at Safehaven for the great presentation. So bye, everyone.
Thanks, Doug. Thank you.